Want to just start? They will. While we're waiting for Eileen to join, we can go ahead and start roll call. I will call members by their first name in the order listed on the agenda, which is alphabetical order and by last name. So we'll start with Emily. Emily. Patrick.
I'm here.
Thank you. Bob. Bob. Paul F. Paul F. Justin. Justin. Nariman.
Here.
Thank you. Adrian.
Here, I think there are several people that are here, but they're not on the panel. So I would look and see, because I know Emily is here. She's just not put on the panel to talk.
I think Emily, that might not be under her name.
Oh.
Emily, are you registered as Nola instead on your screen name? It looks like I can't hear now. Good afternoon, Eileen. We're just taking roll call in the meantime. We'll circle back around to you for welcome after roll call. Sorry about the technical difficulties behind the scenes, Eileen.
Let's go ahead and continue. Jody. Jody, I see you, Emily. Hi. Thank you for joining. Louise.
I'm present.
Thank you. Stacy. Stacy. Eric.
Hi, I'm here.
Appreciate it. Vicky. I believe she said she'd be a few minutes late. Right. Natalia messaged and said she was unable to attend. Sulan.
I'm here.
Thank you. Michelle.
Here.
Paul S.
Good afternoon.
Dorothy.
Here.
And Wes.
I am here. Thank you.
All right, appreciate it. So Eileen, we went through roll call, but we didn't introduce our new member. So I can allow you to do that, or you can have me do that, whatever works best for you.
The agenda. Can you hear me?
Sorry, what was that?
Did you review the agenda?
No.
Okay. All right. Sorry, everybody, for my being late. I thought I had the right connections, but when I opened it up, it was blank. So I don't know what I did. Anyhow, welcome everybody. And I'm glad that you moved ahead without me. Just want to run through the agenda for everybody so that you know, we said, we're going to be introducing a new member, but then we'll review the minutes, open the floor for public comments. Following that, I'll give an update from the cost board meeting. Then Manaza Kona from the Center on Health Insurance Reforms will give us a presentation on state protections against medical debt. After that, Gary Cohen with HMA will lead us in a discussion to help us start prioritizing our potential policy options concerning medical debt. And then after that, we'll wrap up and adjourn the meeting. So again, thanks for all being here. And I hopefully it'll be more productive than what my first 5 minutes of this 2 hours was. And with that, I want to take the opportunity that we have a slide, I think, to introduce a new member to our stakeholder committee. It's Michelle Ratala. I hope I'm pronouncing that right. Is here representing business organizations and was nominated by the Purchasers Business Group on health. And she has 20 years of experience in managing employee benefits up to 340,000 lives, and is currently working for King County Department of Human Resources. Welcome, Michelle. And I don't know, do you have anything else you want to add besides those brief comments we have about your background?
No, nothing to add about myself, but just that I'm looking forward to being on the panel. I know I'm going to learn a lot from the other members and look forward to contributing as I'm able.
Well, great. We welcome, and I'm sure you'll have lots to add to us. So now we can move to the approval of the last meeting minutes. Going to tab 2 in our packet. For anybody that needs it, there's a recording of the last meeting posted on the HCA website for reference. And is there any discussion on did we miss anything on these minutes? No, is there any proposed changes or any problems? If not, is there a motion to approve the minutes?
So moved.
Thank you. That was Patrick. All right. And for the record of Patrick Connor, and a second.
Second.
And that was Eric Lewis. Thank you. So all in favor say aye.
Aye.
Any opposed? All right. The motion has been adopted and the minutes are approved. So now I'll pass it back to staff for public comments.
Thank you, Eileen. Currently, we have no written comments or sign-ins for public comment regarding this meeting. If you have not signed up and would like to provide a public comment virtually, please raise your hand. We will send you an invitation to be a panelist. Please accept the invitation to become a panelist to provide public comments. When you are called, please unmute yourself, state your name and affiliation, if any, before speaking. You are also welcome to provide comments in writing via email at any time. The floor is now open for public comments. Anyone who is interested is free to raise their hand.
Got one, John.
We have one, John Godfrey.
Just take a second for him to rejoin as a panelist.
Good afternoon. Can everyone hear me?
Yes.
Thank you. My name is John Godfrey. I'm a small business owner from Seattle. I also represent Washington Community Action Network and Healthcare is a Human Right. I'm really excited for that and inextricable from the short surprise to see results of a recent survey of 1,000 Washingtonians showing that 44% of small business owners, 41% of people with disabilities, and 34% of people who earn less than $35,000 a year struggle with medical debt. This is unacceptable in a state with robust charity care laws on the books. While some of this can be explained by separately billed providers that don't count as charity care in most situations, there are clear gaps in patient knowledge of their charity care options, which should not be the case in 2024. Almost 20 years ago, Washington Can ran an entire campaign around systemic billing practices at Providence that steer patients away from charity care. And since then, not only that, but then there's been a major lawsuit from the Attorney General. And here today, we have these survey results. So I think clearly there has to be more work done on more stringent enforcement of charity care laws in our state. This many people who are under $35,000 a year should not be struggling with medical debt. Thank you very much.
Appreciate it, John. Thank you. For anybody else?
Don't see any other hands.
Have any other hands? No other hands. We'll go ahead and close the public comment period. Thank you for everyone who participated, and I will pass it back to Chair Cody.
Yeah, I'm having problems today for some reason. Bill, thanks. I just want to give an update on the July 30th cost board meeting. We talked about facility fees from a national and provider perspective with a panel of industry experts. And for policy recommendations, the cost board requested more information. We requested the staff and the consultants to look into modifications of the all payer claims database, requiring ownership reporting, looking into CPT codes from MedPAC and considering PEBSEB modeling, Also to consider unintended consequences and site neutral payments. So we had quite a robust discussion about that. We also, approved new nominees from the nominating committee, including Michelle for this committee and David DiGiuseppe, I hope I said that right, for the advisory committee on data issues. The CARS board also reviewed recommendations from the advisory committee on primary care, the recommendations on how to best achieve our goal, the state's goal of a 12% total healthcare spend being on primary care. The board endorsed 5 of the recommendations that did not require legislative action, and we asked for the recommendations that would require legislative action to actually get some more information, because most of it was fiscal. So we wanted to know exactly how much that would be costing us, and especially if we were increasing our by 1 percentage point annually until a primary care expenditure ratio of 12% is achieved. So what the Medicaid reimbursement for primary care to no less than 100% of Medicare, no later than 2028. So both of those, you can imagine, since I spent so many years on a fiscal committee, we had questions about. So that we sent that back for more information. Now, if you want more details on this, feel free to visit the HCA webpage where the meeting materials and the recording of the meeting are available. And our next cost board meeting, full cost board meeting, is on Thursday, September 19th at 2 p.m. So next, we have a presentation from NASA about state protections against medical debt. She is an assistant research professor in the Center on Health Insurance Reforms, the Health Policy Institute at the McCourt School of Public Policy at Georgetown. And as a review, last time we talked briefly about medical debt, why it matters, collective practices, charity care, and ideas for policies we could look at. So after she presents, Gary with Health Management Associates will help frame the presentation, which should give us some perspective of what other states are doing and what they've done to combat medical debt, and help us in our conversation so we can sharpen our focus about what we want to pursue. So welcome both Gary and Manasa.
Thank you so much. Hi, everyone. I'm Mana Sakona. I'm an associate research professor at Georgetown University Center on Health Insurance Reforms. For those who are unfamiliar with us, we are a sort of think tank within Georgetown Universities, and we work on a lot of health insurance, affordability of coverage, cost of care issues. And I have personally been focused on the medical debt issue for a couple of years now. We have funding from the Commonwealth Fund to really kind of delve into what policy levers are out there at the federal and state levels, and we have been producing reports and briefs and blogs for them, documenting what the 50-state landscape looks like. And you can find all of that on the Commonwealth website, Commonwealth Fund website. And we also have like an interactive map where you can kind of go and like check what's going on in each individual state when you click on it. I highly recommend that as a companion to this conversation today. I thought we could kick things off very briefly by kind of describing the problem. What is the issue here? What the scale of the issue is? Who's being impacted by it? But I want to primarily focus the chunk of today's conversation on what the state policy solutions look like. So to briefly kick things off, what is medical debt, right? So unpaid medical dental bills. It can include, and very often the definition includes past due payments owed directly to healthcare providers, but it is where medical debt is like a bigger problem than just that. It also includes ongoing payment plans, credit card debt for medical bills, and this can be medical bills that you put on a general purpose Visa card, or even more troublingly, a specific medical bill specific credit card, which really have some burdensome interest rates and really kind of create huge problems for patients. A lot of estimates around this tend to not really look at the full picture. A lot of the times they're relying on credit report information to really understand the scale and of the issue, which is definitely undercounting the problem. Sorry, did someone?
Oh, sorry.
Sorry. So Kaiser Family Foundation did what I think is probably the most expansive estimation of the issue, because they did a survey and they really wanted to capture all these other types of medical debt. And according to their estimate, they found that almost 100 million people, or 41% of adults, have debt because of medical dental bills, which is quite staggering. And then one point that I always make is that, medical debt really doesn't have to be like a large dollar amount to really cause problems. I think more than half of the people with debt owe less than $2,500. But of course, most Americans are not able to cover a lot of minor emergency expenses, and even small debt amounts can really be burdensome. And of course, and then the interest rates on medical debt can really snowball even small amounts into large burdens. So it's worth keeping in mind that these are not always starting off as large dollar amounts. Even small dollar amounts can lead to some pretty negative consequences. So in terms of who is holding medical debt, of course, you've got uninsured populations, and this is especially salient for states that have not expanded Medicaid. Those ineligible for Medicaid in those states are one of the bigger categories of people who end up with medical debt. Undocumented immigrants ineligible for Medicaid also tend to face medical debt a lot. But it's worth noting that, of course, it affects insured patients as well. More than 40% of insured adults report incurring medical debt, likely because they had a gap in coverage, or they were enrolled in insurance with inadequate coverage. And what does that mean? High deductibles, high cost sharing that can leave you exposed to unexpected medical expenses. But it is important to note that medical debt burden does not really affect everyone equally. There are disparities in terms of both who incurs the medical debt and then who is sued in court for medical debt. So first, we've seen evidence that shows that Black and Hispanic or Latino families are just more likely to have medical debt than white families. Younger families also tend to have more medical debt. They get strapped down by medical debt far earlier. And then, as you might expect, of course, families who have at least one family member with a disability or experiencing chronic illness are just more likely to have medical debt. And then we've seen some evidence of a study of Wisconsin court records over a period of 17 years that found that Black patients and those living in poorer and more rural areas were just more frequently targeted for lawsuits to collect against medical debt. So protecting patients from medical debt is critical in terms of eliminating disparities and promoting health equity. So where is the debt coming from? So most people, 72% according to one estimate, attribute at least some portion of their medical debt to bills from acute care. So that could be like a single hospital stay or a treatment for an accident. But of course, medical debt can also be the result of physician bills, ground ambulance bills, facility fees charged by hospital outpatient departments. And so while hospitals are a big portion of the problem, there are, of course, all of these other sources of medical debt that, a comprehensive policy solution would take into account as well. And of course, I cannot have the conversation about medical debt and the causes of medical debt without nodding to the biggest contributor, which is just ballooning healthcare prices, right? In many cases, they're untethered from the actual cost of providing care. And at the end of the day, any policies that only target medical debt without really targeting the upstream issues will end up being unsustainable. Charity care policies can only serve as sort of safety net for people who fall through the cracks, definitely not meant as like some kind of broad-based healthcare program. But that said, as we work on the bigger upstream issues like healthcare prices and affordability of insurance coverage, it is worth strengthening this safety net for those who do slip through the cracks and then find themselves facing medical debt. So it is important for for states to really step up and enact some of these robust protections that we've seen. So what do we mean when we talk about protections against medical debt? So there are two major buckets of protections, right? So first, we've got policies that will prevent people from accruing medical debt in the first place. And then second, we've got policies that will protect patients who've already incurred medical debt from some of the more disastrous negative downstream consequences of that debt. So there are both federal and state laws that kind of target these two buckets. And I want to kick things off by giving you a really brief overview of the federal framework when it comes to protecting patients against medical debt, because there are some interactions there that are potentially worth keeping in mind. So On the federal side, the Affordable Care Act added several requirements under the tax code that require nonprofit hospitals to protect patients from medical debt. And we'll talk through the various categories of medical debt protections in a little bit, and I'll make sure to highlight what the federal requirements are versus like where states have filled in the gaps. But before I do that, I just want to note two big picture things. First, these requirements at the federal level only apply to nonprofit hospitals. And of course, a quarter of the hospitals out there are for-profit and they're fully exempt from these requirements. And then second, the agency that's responsible for enforcing these requirements at the federal level against nonprofit hospitals is the IRS. And to put it mildly, they do not have the strongest track record in terms of enforcing these requirements. I mean, you must have come across all the news stories about senators on both sides of the aisle, raising concerns about this and kind of pushing the IRS to do more. And it seems like they've kind of responded to this uproar. And the IRS Inspector General very recently announced that they were going to conduct audits against nonprofit hospitals. So we'll really have to see how that shakes out. It's very much in the early stages. So aside from the IRS, two other agencies sort of come into play here. So you've got the Consumer Financial Protection Bureau, probably another agency that you've heard a lot about in this context. And the FTC too has some role to play here. The two laws that they use to kind of bring to bear in this conversation are, the first is the Fair Credit Reporting Act, or FCRA. It regulates credit reporting agencies, right? Your Equifax, TransUnion, the other third one that I can never remember. But it regulates them, what they can do. It also regulates those who provide information to them. So that's your debt collectors and hospitals. And then the folks who use that information. So that's your prospective lenders and prospective employers, landlords, et cetera. So consumers have the right to dispute any incomplete, inaccurate information and get any outdated information out of there. And in some cases, patients can even directly sue hospitals' debt collectors for inaccurately reporting medical debt to credit reporting agencies. But it's worth noting, inaccurate is doing a lot of work there. If it's an accurate medical debt that's being reported at credit reporting agencies, as of today under FCRA, that's seen as being fine. I mean, of course, the new proposed rules might change that, but I'll talk about that a little later. In addition to that, at the federal level, there's also the Federal Debt Collections Practices Act, which limits how aggressive essentially debt collectors can be when they're reaching out to patients and talking to them. For example, they'll restrict the ways and the times in which they can contact debtors. They'll require certain disclosures, notifications, prohibit them from lying to patients, and those kinds of things. So essentially, kind of limiting the unfair and deceptive practices that they can undertake to collect on debt. So patients can also sue debt collectors for violating this law. But it's worth remembering that the FDCPA does not really limit what legal remedies debt collectors can go for, right? So it doesn't say that, hey, you cannot garnish wages or you cannot foreclose on homes. All of those are possible. It just kind of more so regulates the communication between debt collectors and patients. So now that we have this big picture of like what happens at the federal level, let's talk about the different buckets of protections that we mentioned earlier. So in the bucket of protections for preventing medical debt, there's two categories of policies. The first is financial assistance policies or charity care policies, often used interchangeably, and I'll probably use them interchangeably as we go through this. And the second category is community benefit policies, which I'll talk about in a second. So financial assistance policies, in terms of protecting patients from accruing medical debt, it's really the biggest policy lever that is available to regulators, right? So by this, we mean a hospital's policy under which it says it will provide either free or discounted care to certain patients that are either low income or have particularly high medical expenses. So at the federal level, under the ACA, nonprofit hospitals are required to establish a written financial assistance policy that is widely publicized. But it does not really specify what the actual policy should be. So it does not really say who should be eligible for financial assistance or how much financial assistance they should be eligible for. This is where really state laws can come in and really fill out those standards. According to our last count, about 21 states, including Washington, of course, have established their own standards. And as the public commenter said earlier, of course, these are standards as they're written in the law. Our research does not cover how they're actually being enforced on the ground. So that is definitely a conversation we want to have in the discussion section later. But as far as what's written in the law, we've got 21 states, including Washington, with their own financial assistance standards. And most of them, including Washington, expand the applicability of these standards to both non and for-profit hospitals, which is great. And then some states have set certain minimum eligibility standards requiring hospitals to provide financial assistance to certain low-income patients. And Washington, as you know, is one of those states. It requires patients under 300% of the federal poverty level to receive free care and requires discounts for those between 300 and 400% of FPL. Some states also allow patients with heavy out-of-pocket medical expenses or prior medical debt to access financial assistance, even if they don't meet the income requirements. So I think Maryland comes to mind. I think California is another state that does that. And this is currently something that Washington does not do. Maybe something that's worth looking into. Some states also limit how much hospitals can ask low-income patients to pay by limiting hospital charges to, say, Medicare rates, right? So currently in Washington, patients are eligible for discounts. Those discounts are a percentage of their out-of-pocket costs, but the state doesn't really limit charges for uninsured patients. So that's definitely a gap that's worth closing. Looking into enforcement, so Washington does allow for penalties for non-compliant hospitals. I believe it's $1,000 per fine. And it's unclear these fines have actually been used as a tool yet. So if anybody has any updates on that, I'd love to hear about it once we're in the discussion portion of this call. A couple of states also allow for a private right of action, which is kind of a useful tool because it allows patients and legal services organizations representing them to really actively enforce the law. It kind of takes a little bit of burden off of the state itself. And then finally, it's worth noting that merely having standards to require financial assistance policy is not enough. A lot of the times applying for financial assistance is really, really cumbersome. There's plenty of anecdotal evidence and ask anybody who helps folks with these application processes. They tend to be like college applications. There's some evidence that it can also be discriminatory in terms of who receives information about the existence of financial assistance or who receives help with the financial assistance application, right? So some states have established guardrails to sort of protect patients during this application process. So some states have, for example, required hospitals to provide certain kinds of financial counseling or to give them access to counselors who can help them complete the applications, and others have created uniform applications to really kind of limit the burden on patients. Both of these currently Washington does not do, so that's something worth considering. The biggest thing I think that has been helpful is adding presumptive eligibility. So that means that if a patient is already eligible for another income-based program like SNAP or EBT or whatever, then they are automatically considered eligible for financial assistance, and then they don't really have to go through all of the cumbersome application process. This is something that we've seen Oregon implement, and I believe Illinois is another state that does it. Something that can really, really remove the burden from patients and ensure that the maximum amount of people who should be eligible for these benefits are actually receiving them. Barring a presumptive eligibility process, I mean, a requirement to screen for financial assistance is important. I know that Washington requires a screening before the bill is sent to collections, which is, compared to some of the other states, a little bit more downstream. You want this requirement for screening for financial assistance to be as close to the point of sale as possible, right? So maybe even before sending a bill to the first bill to the patient to begin with. But right now, the requirement to screen kind of falls right before sending to collections, which already creates kind of like some confusion and really just, it might lose, folks who are eligible for this might kind of drop out and not receive the benefits. And then it's also important to kind of limit what supporting documents can be required. And this is somewhere that I think Washington actually does do a pretty good job. You guys do require that the procedure is not place an unreasonable burden and kind of limits, hospitals from asking for duplicate forms of verification, et cetera. And that is, I think, a good policy to have in there. And then excluding certain kinds of assets from being considered during this application process is also important. While Washington, unlike a couple of other states, does not prohibit the consideration of assets, it does kind of limit some of the assets. I believe equity in a private home and your vehicle are excluded in the asset test. So I think that is a helpful thing that the state already does. So moving on from financial assistance policies, the other category of laws that prevent the accumulation of medical debt is community benefit requirements. So what are community benefits? Community benefits frequently include charity care financial assistance, but that is a subset of the bigger bucket that is community benefits. Community benefits can also include, for example, investments that address workforce issues or a lack of access to food or housing, sort of bigger investments in the community. So in the long run, the theory is that these investments will reduce medical debt burden by improving population health and the financial stability of a community. Under federal law, nonprofit hospitals are required to conduct a community health needs assessment every 3 years and then adopt an implementation strategy on how they're going to provide community benefits. And the theory behind this is that nonprofit hospitals are obligated to provide tangible benefits to community in return for the massive tax breaks that they're receiving. It's a quid pro quo. But the federal requirement around community benefits are pretty vague. For example, federal law does not really require hospitals to spend a certain amount of money on community benefits or specifically even financial assistance. And states do have the option of expanding those community benefit requirements. We've seen a couple of states even expand community benefit requirements to for-profit hospitals by leveraging the state certificate of need process, which is kind of interesting. You see that in DC and Virginia, for example. And then states can also get more prescriptive in terms of how hospitals define community benefits and how much they should be spending on community benefits. For example, Illinois and Utah require nonprofit hospitals to spend whatever amount of tax liability they would have had to pay, and they have to spend that on community benefits. So that creates a tangible amount that a hospital has to dedicate towards community benefits. I'll also note the unique case of Pennsylvania, where the local taxing districts really have the power to sue hospitals for not holding up their end of the bargain, and that's been a really, really active source of enforcement and has really helped keep hospitals in check, ensuring that they are paying their fair share in community benefits. So from my understanding and our research, it looks like Washington requires nonprofit hospitals to report on its primary community benefit activities. It requires some details on who is benefiting from these activities, but does not really set any minimum amount for how much these hospitals should be investing in community benefits or in financial assistance specifically. So now that we've discussed these two categories of laws that prevent the accumulation of medical debt, I want to turn to the bigger bucket of protections that protect patients who already have incurred medical debt. So here there's two major categories again. So first, there's regulating hospitals and debt collectors' billing and collections practices. And then the second is to protect patients in the context of like legal action to collect on medical debt. So in terms of regulating billing and collections practices, there aren't really too many protections here at the federal level, but many states have really stepped up in this space. But unfortunately, Washington's laws are not necessarily really robust, especially in terms of these billing and collections laws. So, for example, a few states like California, Colorado require hospitals to offer low-cost payment plans, right? So they set limits on how much hospitals can collect from patients monthly based on patients' income. Colorado especially is really most protective in this sense. They require hospitals to even discharge the debt once the patient has made 36 payments, which is just really a huge win for patients. Washington currently does not require hospitals to offer payment plans, and it definitely does not limit how much they can charge monthly on a given payment plan. So that's definitely a gap that's worth talking about. Then interest rates. So Washington does limit it, but it's at a pretty high 9% right now. So other states that have limited interest rates for medical debt have gone much lower. I'm sure you've all come across the news stories about the ballot measure in Arizona, which limited interest rates that hospitals and collectors can charge on medical debt to 3%. 9% can really potentially lead to, snowballing of the amount of medical debt. So it is worth considering whether it makes sense to further limit that allowed interest rate on medical debt. Many hospitals contract with debt collectors who collect unpaid bills on behalf of the hospital. We've seen a few states that require hospitals to be responsible for the actions of the debt collectors that they're contracting with, right? And we've seen states actively require hospitals to be responsible for the actions of the debt collectors that they contract with. But currently, Washington does not really have those oversight requirements, which might be something else worth thinking about. Further, we've also seen states that have prohibited the sale of medical debt to third-party buyers. So historically, third-party buyers who buy medical debt tend to be just far more aggressive in their collections practices and far more likely to sue than hospitals, because that's just their entire business practice for the most part. And so states have chosen to regulate these sales. A couple of them, like New York, I think California, fully prohibit the sale of medical debt to third parties, but others have chosen to kind of place certain guardrails on that sale. So they require the seller and buyer to enter an agreement where the buyer agrees to uphold certain patient protections. Currently, Washington does not really regulate the sale of medical debt. I think there is a waiting period, but after that, hospitals are free to sell the debt without really any strings attached to it. And then finally, there are several states, and many of them very recently have passed these laws. They prohibit hospitals and debt collectors from reporting medical debt to credit reporting agencies. And then it's a sort of belt and suspenders approach that a lot of them use now. So on the one hand, they stop hospitals and debt collectors from reporting medical debt to credit reporting agencies. And then on the other end, they prohibit credit reporting agencies from keeping medical debt information on file and including them in any reports that they generate. And it's worth noting here that the CFPB, like I mentioned earlier, has proposed a federal rule that could prohibit credit reporting agencies from including medical information in reports that they provide to prospective creditors and lenders. But it is worth noting that the rule is, as it's been currently proposed, it wouldn't apply to credit reports generated for the use of prospective employers or landlords. And the other big gap is that it would really only prohibit medical debt that's owed directly to hospitals from showing up. So all of your other medical credit card debt, for example, will still show up. So there are some gaps there, and that's why I think it's important that a lot of states have kind of stepped in and kind of filled those gaps. And so now that we've discussed the ways that, to protect patients through the regulation of billing and collection practices, we can turn briefly to protections against legal action. So first, we've seen several states fully prohibit the placing of liens or foreclosures on primary homes to collect on medical debt. So here, Washington does have a fairly generous homestead exemption protecting up to $125,000 in equity in a home. But other states have chosen to kind of fully prohibit this practice, which is definitely kind of removes the incentive that debt collectors might have to really sue patients, and I think that can be a massive increased protection for patients. The other element that we looked at is wage garnishment. So federal law currently does protect a certain minimum amount of patients' wages from being garnished to collect on debt, but this is a very small amount that we're talking about. I think they protect, like, say 30 times the federal minimum wage, which is a very small amount. But some states have kind of expanded this, and we see that Washington has very slightly kind of increase the amount of a person's wages that are protected from being garnished. But we have seen other states that actually fully prohibit the practice. They say that, you know, if you want to collect on medical debt, yeah, you can't do that by garnishing wages. And they just have, and I think these are far more protective, and it really does potentially remove a lot of the incentive to sue patients to collect on medical debt. And then finally, while I know this is not the flashiest protection that a state can enact, it's just really important for states to establish robust reporting requirements from hospitals to ensure that any protections that are currently in place are working as intended, and then to root out any potential patterns of discrimination. So currently, Washington requires hospitals to report the total dollar amount spent on financial assistance, the number of applications submitted, completed, and approved. But many states, including the leaders in the medical debt protection space, like Maryland and Colorado, now require hospitals to report this information broken down by race, gender, ethnicity, so that the state can really track and see if there's any discriminatory practices taking place at a given hospital. And this information can really help Washington understand how well these policies are really working for everyone. And then Washington could also really beef up its reporting requirements by requiring hospitals to report on how many liens they're seeking or how many patients' wages they're currently garnishing to understand the scale of the problem. This is another a reporting requirement that currently is not in place that I think could really help understand the scale of the issue. So I know I've thrown a lot of information at you, so I'll pause right there and pass the baton on to Gary.
Thank you very much, Manasa. And that was a really excellent summary, both of where we are and some of the policies that states have adopted to address the question of medical debt. Leading into the discussion that we're going to have, I want to give a little bit of background on what the cost board has been looking at and what it's looking for, some guidance from this committee. So the cost board, as you, of course, is charged with identifying causes of rising healthcare costs, and this year has been looking specifically at what policies it could recommend to help address rising costs. And one is the role of facility fees, which I think we talked about at a previous meeting of this committee. And the cost board has asked for more input from the stakeholder advisory committee on policies to address medical debt. Next slide, please. So today we've had an overview of the issue from Manasa. I'm going to talk a little bit about more specifically about current laws in Washington that relate to medical debt. And the goal is to begin identifying prioritizing policies that might address medical debt in Washington and identify any other areas where more information would be needed. And then next meeting, we'll have consumer groups talking about the impact of medical debt and some of the policies that they have put forward to address it. Next slide, please. So to focus specifically a little bit on Washington, according to KFF, Kaiser Family Foundation, about $4.2 billion in medical debt is owed in Washington state. 6.5% of adults in Washington report having medical debt. So it's a significant issue impacting a lot of people. And then on the question of charity care, in fiscal year 2022, Washington hospitals reported $1.134 billion in charity care, which represented 1.26% of total hospital revenue and 3.48% of non-Medicare, non-Medicaid revenue. Next slide, please. So current law in Washington, and Manasa touched on some of these, hospitals are required to develop charity care policies, and there are some specific provisions relating to providing either free or discounted care, which are laid out here. The requirements are a little bit different for larger hospitals than for other hospitals, but all hospitals are subject to requirements to provide either free or discounted care, depending upon the income level of their patients. And I think we've talked about this before. In February, the Attorney General reached a settlement with the Providence Hospital System over its failure to offer charity care to those who are entitled to it, requiring $158 million in refunds and debt forgiveness. And as Manasa mentioned, it's often been identified that either people aren't told that they're maybe entitled to free or discounted care, or the processes to apply for it and be determined to be eligible for it are burdensome or challenging in one way or another. So that's one area that the state could potentially address to make sure that people are getting the benefits to which they're entitled to. And Manasa also mentions there are states that require hospitals to provide a minimum amount of charity care. Washington does not. And Manasa mentioned 2 states that link the amount of charity care to the tax benefit that not-for-profit hospitals get. Oregon has a formula which looks at the hospital's revenue and operating margin to determine the amount of charity care that it's required to, that they are required to provide. Next slide, please. So I think Manasa covered most of this in terms of billing and collections practices. Again, specific to Washington, Washington does require a waiting period and a screen for eligibility for financial assistance before a bill can be sent to collections. It requires a waiting period before medical debt can be sent to a credit reporting agency, but does not prohibit that practice. And some states require hospitals to offer a payment plan. As Manasa mentioned, how much people can be required to pay per month, for example, depending on income. And Washington does not have that sort of provision. Next slide, please. These are just the references. So if we could skip down to tab 7, I think, or tab 6. Sorry, you're right. So this is just a list of some of the ideas that have come from members of the committee. And they fall into the categories that Manasa talked about in terms of, on the one hand, policies that would prevent the accrual of medical debt, and then on the other hand, policies that will address how medical debt can be collected, and what happens once people actually have accrued medical debt. One thing that I came across today actually was a news story of a somewhat different approach, which is that the governor of the state of New Jersey announced that the state is going to invest $100 million in acquiring and forgiving medical debt for people in New Jersey. So the idea being that there's organizations out there that buy up this debt at a discount, and then the state, using money from the Inflation Reduction Act, is going to then purchase that debt and forgive it. So that's obviously a different sort of approach to helping people who have accrued medical debt. We'd like to have a discussion. Next slide, please. We'd like to have a discussion today and hear from you all as to what types of policies you're interested in seeing the cost board look at and potentially recommend to the legislature, both in terms of which types of policies, as we've discussed, and then the specifics of which policies you think are the ones that are the most likely to achieve the kind of results that we're looking for. So I would open it up for discussion from members of the committee.
Carrie, it looks like Michelle has her hand raised.
Yes, hi. Let me make sure I lower my hand. Okay. Gary, you kind of stole my thunder a little bit because when I was reading the agenda yesterday, it reminded me of a podcast I had listened to about an organization which at that time was called Rest in Peace Medical Debt. And I Googled them, and they're now they call themselves Undo Medical Debt. And I saw there some articles that they had on that website that Cook County, Illinois, and the city of New York City had used them to buy up medical debt from members in their community. And it's forgiven, and it's no longer part of their record, and it's not harming them in the future. So it doesn't prevent it, but it's a way to ameliorate it after the fact, and perhaps some of the community benefits that Manasa was talking about earlier, some of the responsibilities that hospitals, so maybe they could be made to buy up that debt. Just a thought.
It looks like Emily was the next person that had her hand raised.
Thank you. Well, I appreciate that thought, Michelle, and also all the informative presentations, which contain just a wealth of information. I have so many thoughts on this topic, and I'll maybe start with a couple of items. One is that I think it is important to understand the prevalence of medical debt in Washington State, and Gary mentioned some information from national data sources that suggests medical debt hovers about 6% in Washington, but that's typically been measured as debt that has been sent to collections, so kind of at the end of the line. And Mr. Godfrey, who spoke earlier when in the comments, mentioned that there's recently been a survey of 1,000 Washington residents plus that measured medical debt more broadly, looking at the credit card debt, the past due medical bills that people have sitting on their counter but can't pay, and the everyday medical debt that people are facing before they get dragged to the courthouse, basically. And that, as Mr. Godfrey shared, showed that across pretty standard across all income levels, that we were hovering more about 30% in Washington State, or 3 in 10, which is quite a striking figure and more than I expected, honestly. And so that, I think, points us to the depth of the problem, and the depth of the problem that has not really been measured in Washington to date in a meaningful way. That data also discussed disparities, as we were talking about earlier, small businesses, certain populations, people with a disability, much more likely to fall into medical debt in that survey. So I think there's a very important role for the cost board to play in furthering that data analysis to understand the prevalence of medical debt, where it's coming from. The survey also suggested that 4 in 10 say that the largest share of medical debt came from hospitals, but there were other sources, and really to kind of dig into that information. So I wanted to share that as a starting point with the group, and echo Mr. Godfrey's concern there, and suggest that might be something to bring back in the future. The second piece that I'll just raise very briefly is that I think any serious discussion about medical debt in Washington needs to address the elephant in the room, which is that we are not doing all that we could do to enforce our existing law. So we have, for example, 2 rounds of statutory improvements to the hospital charity care law from 2018 and 2022 that have not yet made it into rulemaking at the Department of Health, let alone robust enforcement other than occasional Attorney General office intervention, which really, again, should be the end of the line rather than a starting point for shared understanding about how charity care ought to work in Washington. So I appreciate the comments that were made about making sure that we're paying attention to the laws that we have on the books and that they're well implemented and that all stakeholders understand them and how to apply them correctly before we have to get to the AG's office. And then third, because I know that there are a number of folks waiting to speak, I really appreciate Professor Kona's enumeration of the many ways that we could improve the situation, that kind of dire medical debt situation that we were talking about earlier. When I sat down to make my own list this morning, I just things that I hear about from legal services advocates in our community and the things that their clients are struggling with. My list was 10 deep and 20 deep and growing. But our role on the cost board is to address the underlying drivers of cost growth. And I think it is critical that we not lose sight of that we not think only of what is really a Band-Aid solution, and that we encourage the board as a whole to be not only paying attention to these kind of stopgap solutions that people find themselves in need of, but really paying attention to the reason why they find themselves in that situation in the first place. And so as the cost board thinks about these issues, would encourage them to ask the question about why medical debt is so prevalent at this moment in time. Thanks.
Hey, Emily, on your first point, which the results of that survey are truly shocking. Am I right that the state is not collecting this data itself? And if that is right, do you have any thoughts about what the best way to do that would be? Because we'll be talking with the data committee later on this afternoon. And I think it would be helpful to think about how the state might gather this data in a more comprehensive way, but also in a way that would be the least burdensome. I mean, and the most effective. If you have thoughts on that.
I do, yeah. Thank you for asking. The state is not collecting this data yet, but House Bill 1508, which passed last year, charges the cost board with collecting this very kind of data in the future. And I believe that is supposed to start in 2025, would defer to staff, but that's critical work. And House Bill 1508 suggests important data collection methodology with respect to demographics, making sure we really understand disparate impacts of underinsurance and issues like medical debt. So I hope that's work that's well in the cost board's upcoming agenda. This is not a new kind of process. Many other states like Massachusetts, California, et cetera, collect similar sorts of information. So it is actually pretty easy to collect this information when we try.
It looks like Eric was the next person that had his hand raised.
Well, hello. Thanks for the opportunity to make a few comments. I really agree with Emily in her point on we need current Washington state data, really, if we're going to have effective Washington state consumer medical debt policies. And I think without current data, we might miss the mark on our policies. And I will say that in 2022, the state legislature expanded charity or financial assistance that hospitals provide their patients significantly. This went into effect in 2023. So I think looking at more current data will give a better idea. When just even looking at 22 data, I think may not give you the right information. And as it was pointed out in the presentation, hospitals are just part of the healthcare system, and patients can acquire medical debt from other sources like ambulances, ambulatory surgery facilities, physician groups, dental groups, and as everybody knows, only hospitals are subject to the state's charity care laws. So a lot of patients may be accumulating debt from other sources that aren't from hospitals. And I think in looking at the national data, Washington is among the lowest medical debt states in the nation. I think the Urban Institute map cited by HMA had Washington in the top 10 of lowest percentage of people with medical debt. Not that we shouldn't pursue a policy, but I think Washington starts off in better shape than, say, a state like Texas that hasn't expanded the Affordable Care Act and doesn't have any charity requirements on hospitals. And I think certainly Washington State's focus on expanding the Affordable Care Act and the charity care policies that hospitals are subject to really helps in this area. I think when we've been looking at medical debt and in 2022 data that was cited in the slide deck, we looked at 990s for all the nonprofit hospitals. And we actually come up with a higher number because the number in the 990s includes more than just the hospital charity care. It includes other services that hospitals provide, such as physician groups, skilled nursing facilities, and home health agencies. And I really think that national data isn't useful when we're looking at medical debt for Washington, mainly because Washington has unique existing policies. And I think we want to target any solutions to Washington State data, just so they can be the most effective as possible. And the last thing I'll say, when WSHA looked at the IRS 990 forms for hospitals, we looked at the charity provided by hospitals, but also hospitals, at least in 2022, provided Medicaid services at $2 billion below costs, and Medicare services at $1.2 billion below costs. Now, Medicaid, there was some improvements with the supplemental payment system that was implemented by the legislature, but hospitals not only provide financial assistance charity care, they also provide Medicare or Medicaid services at a below cost rate. So I'll be quiet now. Thank you for listening.
Thank you, Eric. It looked like Sulan had his hand raised next, and then Adrian after.
Hi, I'm glad to be here with everybody. My name's Sulan. I come from SCIU 1199 Northwest. I use they, them pronouns, and glad to be in this conversation. I want to be brief so that everyone can speak, but to start, I just want to echo Emily's earlier points, especially around the role of this committee to collect data, analyze the data, and audit current infrastructure around medical debt, charity care, etc. The other points that I wanted to raise in terms of more information to be gathered and potentially recommendations to send is around upstream policies in connection to demographic data and patient outcomes. It would be really great to see particularly race data, but also gender data, including trans people and gender expansive people, and really talking about the relationship between price, quality of care, and medical debt. The next thing I wanted to flag or mention is around the evaluation of healthcare systems' roles in implementation of their charity care and debt policies, particularly considering the role of blockchain and other technologies, especially predictive technologies in the medical debt process. One example I think of is a local Washington State healthcare system uses a blockchain and predictive technology model to sort patients into different groups of payers, depending on the likelihood that they will pay their debt. And then depending on what group they're in, they might experience more or less outreach from the system. So yeah, just wanting our policies and audits to be current with today's technology. And then finally, really wanting to see an audit of state and current practices. Often I think of the important work that the Department of Health has done for a long time in collecting charity care data from hospital systems, but also how sometimes aggregate data can create insufficient information, particularly when it's framed in contrast of large numbers like operating revenue and net patient service revenue. So I'll pause. Really appreciate this conversation. And so I guess the last thing is I also really liked how Eric brought up the ambulances and the clinics and all the other parts of the healthcare systems that also have important implications in medical debt and patient care. All right, I will end at that. I'm really excited to keep talking about this and pass it on to Adrienne.
Thank you so much, Sulan. It feels really good to know that we're all aligned with everybody who has just spoken. I won't repeat everything, but I had written down almost everything that our previous panelists have brought up. For me, when I'm looking at this, I want to be intentional about recommending policies that are equitable. And so with the transparency of reporting and getting that information, I think will really help in keeping an equity lens. And I think having the standardized like application that Manasa was talking about, as somebody with my own lived experience going through these applications, it actually is harder than me applying to UW. It was much more complicated. And so having a uniformed, simplified application and then that presumptive eligibility would really lift the burden off of the consumer, which is where we need to be focusing on, because that burden, again, I can speak from my lived experience, was detrimental to my autoimmune disorder. It really was. And so I want to just voice that we're going to propose really good policies, but I want to keep the equity lens on there. And then let me see, what else the transparency and reporting, I did talk about that. I think that is very important. And then my last point is that Manasana, sorry if I say that wrong. I just want to echo, you said it so beautifully that these safety nets on medical debt, while they are helpful, they don't fix the upstream issue, which is rising healthcare costs, right? That's our systemic issue, and medical debt is just a symptom of that. And it was really beautiful how you said that, these policies won't be equitable if we don't face the systemic issue. So I really appreciate everybody's feedback and our really beautiful presentation. And I think that's all that I have.
To summarize a little bit of what I think I'm hearing, it seems as though it may be possible to have a consensus around some of the issues relating to this topic. For example, the need for accurate and more comprehensive data that covers all of the sources potentially of medical debt, not limited only to hospitals. Secondly, in a variety of ways, making sure that the current laws are being complied with and enforced if they're not being complied with. And in one aspect of that, making it easier and less burdensome and more equitable for people to get whatever the financial assistance they may be entitled to, number one. And then on the enforcement side, making sure that the rules that are currently in place, are being complied with and there is enforcement. And it feels as though no matter where you are sitting with respect to the healthcare system, whether as an advocate or a patient, or whether as a hospital, or those may be issues that we can have some agreement on. That we should at least know what the data tells us, number one, and we should at least be complying with enforcing the laws that are currently in effect. And then moving beyond that, when we go to the question of how do we avoid medical debt in the first place by addressing the high cost of healthcare, I think we may have more disagreement depending on where people are in terms of what the solutions to that to those issues are, and obviously the cost board is very much engaged in looking at those kinds of issues as well, along with other parts of the state. The Universal Healthcare Commission, the Insurance Commissioner's Office, the HCA, but a number of different approaches are being taken to those issues. So I think what would be helpful, I know we're going to have a presentation at the next meeting from a consumer perspective, and maybe we could begin to focus initially on those approaches for which a general consensus can be reached, as well as moving on to somewhere that may be a little bit more controversial. Let's put it that way. If that makes sense. Emily, yeah.
Thank you so much for summing that up, Gary. That I agree with much of that. I'll maybe suggest one gloss for the group to consider, which is I want to make sure that we're not suggesting that we need to wait for perfect data before considering any improvements to the medical debt situation. And I think there is plenty of data and information in Washington about the impact of medical debt and related challenges. I know, for example, in my organization, I've said this previously. I don't want to work on charity care issues, but over and over again, when I go to community presentations, what comes up are charity care issues. People from different diverse communities talk about the challenges that they're facing. And so I don't want to suggest that there is a paucity of information, because we do have plenty of feedback now from impacted communities about the struggles that they're facing. And there are, I think, opportunities to consider improvements even as we go to the next stage of looking at more detailed information, thinking, as Adrian mentioned, about the best, most equitable way to tackle these challenges, and going back to the overarching point of why they're growing and continuing to become so severe.
That's fair, and I didn't mean to suggest anything other than that. I mean, and certainly we're all familiar with the expression of not letting the perfect be the enemy of the good, and so we don't want to. I agree with you. We don't want to let the need for better information prevent us from taking steps that we could take now to address what I think everyone recognizes. To the extent that there's a problem, it's a big problem. I mean, it's affecting people in a very kind of serious way. Louise, you have your hand up.
Yes, thank you. I want to comment on one of the issues of where medical debt also starts. And it has been mentioned, but I think it needs to be emphasized that the cost of insurance and the high deductibles are often where medical debt starts, for two reasons. One, because people will sometimes not purchase insurance because of its cost, and they calculate a risk of whether or not they're going to need it versus how much it will cost them per month, plus the high deductibles that people have. And I'm pondering how the marketplace can be better made transparent. And every attempt to open up the reporting from the health plans is met with great resistance by the health plans, of course. So we don't know, or I would say we don't have very accurate information as to why rates keep going up. And I think there's more that could be done to empower the Office of the Insurance Commissioner and to regulate the health insurance industry so that more people could have better access to insurance and better access to better insurance. And I think instead of focusing just on what could we do with the reporting and the enforcement of what exists, we might want to take a little bit more of that upstream look at how we can prevent medical debt from starting in the first place.
Adrienne, I think you had your hand up next.
Yeah, thank you for that. I agree with Luis and with Emily that I don't think this should prohibit us from moving forward. We do have really good data, and that should not prohibit us from moving forward. As somebody who, has suffered the detriments of medical debt, not doing something to get more data just further exacerbates current health issues, especially those furthest from opportunity. And we need to be aware of that and address that. So that's all I wanted to say to that.
And then Sulan, it looks like you have your hand up again.
They do. Yes, thank you so much, Luis, for bringing up the important need to regulate and improve insurance access, both private insurance and on the marketplace. That's the other thing that I wanted to say, which I forgot to say in my first comment, but glad we're doing one more round, is around the importance of being able to access care initially when you need to access care. We know that healthcare becomes more and more expensive and people accumulate more and more debt when they avoid getting their healthcare in the first place. Obviously, it's way more efficient for the consumer as well as the system if consumers receive healthcare in the site appropriate place, and gets more and more expensive and inefficient when patients are going to the emergency rooms or going to receive expensive treatments for things that could have been dealt with initially. So really thinking about the role that charity care and medical debt play in sort of like rehabilitating or repairing the relationship that Washingtonians have to our healthcare system, really wanting people to feel okay to go get healthcare and to trust that they'll be treated in a financially just way. And then particularly for our members, many healthcare workers have significant amounts of medical debt, and also experience wage garnishment and other financial implications from their own employers. They provide healthcare to themselves. They receive healthcare at their workplace, and then experience medical debt from their employers. And so in this case, there's a double impact of the distress or distrust in the healthcare system related to medical debt. And yeah, we want to make sure healthcare workers keep going to work to help the systems run effectively. So I just wanted to add that piece on, really looking forward to making sure that all Washingtonians can trust in our healthcare systems.
Oh, it looks
Emily.
like Emily has her hand raised.
Okay, I'm not going to talk this much always, I promise. One more thought. To the Louise's good point about the rising insurance costs and underinsurance, I agree that's a very significant concern, and there is more, I believe, that the insurance commissioner's office could do to elucidate the reasons behind rising premium increases. I am one of the people in the state who reads the rate justification forms, so I know that some of that information is there, but it could probably be drawn out a bit. But I also don't want to lose sight of the fact that one of the line items that is always there in the OIC rate justification increases is medical and pharmaceutical trend. And often in the actuaries' justifications for their rising premiums, they will cite to rising underlying healthcare cost trends. And for that piece of data, there is no rate review. There is no entity that takes a look at the underlying entities that are providing the care and reviews the soundness of those increases. So I just want to make sure that we don't lose the layers in that piece of the conversation, though I really appreciate the point, Louise, and agree.
And I would just add that we're looking at some pretty discouraging projections for what the rise in the cost of whether it's employer sponsored insurance or elsewhere are going to be. One of the reasons that's been identified for that, as I'm sure people are aware, is the high cost of some of the new therapies that are coming on, becoming available, the diabetes / weight loss drugs, etc. And there's little that the state can do to impact those prices. And so I guess where I would end up is to say that every time we get involved in these discussions about what we might do, it doesn't take long for the issues to get blown up into like, here are all the problems with the healthcare system. And we are not going to solve all the problems with the healthcare system. And just as I take to heart Emily's comment that we shouldn't let the perfect be the enemy of the good with respect to data, we also shouldn't let the perfect be the enemy of the good with respect to some of the problems that we can solve and keep us from addressing the ones that where we can make a difference, right? So I would just, we're going to come back to this issue again. I would really encourage folks to think about in the different categories of ways of addressing medical debt, what are the 1, 2, or 3 policy options that you really would support and think would be the most impactful, so that we can end up either at our next meeting, of the eventually where the cost board would be in a position to take your input and make some specific and focused recommendations, so that we are taking advantage of the opportunity that we have to try to have some influence on the future course of what happens in Washington through steps that could be taken either by the legislature or by the agencies through the regulatory process.
Well, I think we've had a good discussion this afternoon. I'll just say this is the end of our presentation, but I'll encourage people that didn't take the opportunity to speak or didn't have at this point didn't have anything to say, that if you've come up with questions or ideas, please send them on to staff so that we can have it queued up for discussion at our next meeting. And also just remind everybody that the recording and summary of the meeting will be posted on the HCA website. And I want to thank our presenters, Gary and Manasa, again, with good presentations. And remind everyone the next stakeholder meeting's on Wednesday, November 20th. And with that, unless somebody has anything to jump in to say, that we can adjourn this meeting. I'm just looking around, any hands? Okay, everybody, thanks a lot, and the meeting is adjourned.